Okay, so let's start probing these teeth, and I'm going to actually start on tooth number 3 here. For video purposes, I may not use the mirror, but you'd want to be using your mirror to see the probes. I did put some pencil lines on these teeth. I put one on the distal buccal line angle and on the mesial buccal line angle, because remember, each tooth you're going to record 6 readings, but you're going to be probing the entire circumference of the tooth. So when you start at the distal line angle, you're going to get on that line angle, you're going to insert the probe to the base of the pocket. You're going to do little 1 millimeter walking up and down, and you're going to keep walking until you get to the contact area. When you get to the contact area, you're going to just pivot a little bit so that you can get under that contact, and you're going to get the call area. So whatever the deepest number was from here to here is the number that you would record in your distal little box, okay, a 3. Now remember, this probe is a marquee probe. So if I'm down to here, I'm going to call that a 3, but if I go into that a little bit in the black, I'm going to call it a 4. That's just subjective. You are allowed to be calibrate with the instructor up to 1 millimeter. That's true for most offices as well. So you might get to that and call that a 3. I call it a 4. Within 1 millimeter, it doesn't matter. So that's how we would get that distal. We would walk it back, very, very tiny little walking strokes, and we stay adapted with the 1 to 2 millimeters of the lateral side, or any side of the probe for that matter. Let me just go back on this distal again. You can see that I'm on a lateral side. When I get to that call area and I get under the contact, I'm still on a lateral side. When I walk back, I'm on a lateral side. Now I'm going to get the deepest reading between the 2 line angles. So I'll put a 2 in that. That's where I got that middle box. And then I'm going to keep going. Now I'm starting at the mesial line angle. I'm walking, trying to stay parallel as much as I can. And that means parallel to the tooth surface. This is not parallel. That would be subgingivally, you'd be into the tissue. That 1 to 2 millimeters must always be in contact with the tooth. So I'm walking it. I get to the contact. I can't walk any further. I'm going to tilt it a little bit so I can get under that contact to get the call area. And now I'm going to go to the next tooth, number 4, at that distal line angle, place my probe in the get ready zone, slide it to the base of the pocket. Now remember, Dexter doesn't have a base of a pocket, so you don't go in so far. Practice your walking. Now you notice I'm on the back side of this probe, and I'm going to tilt it, and there I am. I'm going to come around, and as I rotate, I'm on the lateral side of the probe. I got a 2 millimeter on that direct buccal aspect. Now I'm going to start at the mesial line angle and walk it. And you can see I'm kind of on the face of that instrument. So let's just talk about that, because I didn't talk about that before with the parts of the instrument. We typically don't give assessments face, back, and lateral sides, but I think it's good to make a reference point knowing that this is circular in cross-section, which means you can use all sides. So if you were to hold this where it's pointing at you, that's the face. This is a back, and this is a lateral side, and that's a lateral side. And our probes have a blunted tip. They do not have a pointed tip. They have a blunted tip. So the reason why I stopped to do that is in order to stay in contact with the tooth, you're often having to pivot on your fulcrum a little bit to stay adapted. And you see here I'm on the back, now I'm on the side, and now I'm on the face of that working end. So that's how you're going to stay adapted without over bending your wrist. So you're literally going to go from tooth to tooth, and you're going to be recording the deepest probe depth in each section into your box and under the contact and tip. This is where now you'll start to climb up into your 10 to 12 o'clock as you're doing the anterior teeth. And the same thing, you're always starting at a line angle. So when I'm on this upper right, I'm starting at the distal line angle and walking back. I'm still walking all the way across that facial, and then at that mesial line angle, I'm going to keep walking. I can be on intraoral fulcrum now. And here, I have a 4 millimeter pocket there, and I'm going to go to the next tooth. In other words, we're always starting at a line angle. We don't start midline on anterior teeth like we did with our Explorer. Of course, when I get to midline, I'm going to have to start at the mesial line angle. Mesial, walk it into the mesial, and then bend, tilt your probe to get under the contact, to get to the call area. And so this is why you're calling out midline if you have a recorder, because at the midline you have mesial to mesial facing each other. But then I'm going to continue all the way across. So as I record my numbers, it's a continuous line of numbers going from 1 to 16 all the way across. And then you would change your clock positions in the patient's head position as you continue on. I'm on a posterior sextant now, but it's little tiny baby walks, recording the deepest one in each one. Now some of you might say, how do I read the probe? How do I know that that's 3 millimeters? Sometimes you can't always see how far in you are, but you can see what's left. So if I know that this is a 12 millimeter probe and I'm very distal and I can see this much of that left, I'm going to count those bands that I can see. I'm going to go 3, 6, and gee, there's 1 there, so that's 7 left. That probe reading must be a 5. So sometimes you can see how far in you are, but sometimes you can just see what's left. So you'll have to figure out how you want to choose to read your probe, but make sure you're reading it accurately. So tooth to tooth. And remember, Dexter doesn't have a junctional epithelium, so there we go, we're continuing. So now I did my entire facial aspect here. Now I need to move my sequence, and I told my recorder, now I'm going to start on the lingual of number 2. I'm already in the proper clock position. I'm going to bring my mirror in, and now I get to start right on that tooth. I'm going to look in my mirror at the distal line angle. I'm going to, on the get ready zone, slide it in. I walk it back at the contact. I need to tip it a little bit to get under the call area. I walk back to that line angle, and now I need to walk all the way across that lingual, record the deepest number between the line angles, and then I continue this process all the way across, adjusting my clock position and the patient's head position to do all of these teeth in each sequence. I want to talk about the call area a little bit. So when you have the interproximal contact, the tissue that's directly apical to that, this area is called the call area. So remember, this area is non-keratinized, which means if they start to get a periodontal breakdown or infection, it's going to take place in this area, especially if one does not floss. So we cannot miss getting the call area. So when you're walking your probe and you hit that contact, you must pivot, tilt your probe so then you can now get that depth right in the center of that call. When you come from the opposite aspect, you're walking your probe, you hit the contact, you must pivot so that you can get under that contact so that you don't miss that call area. So that's what we're referring to when we are coming across contact, and then you have to pivot it out to get under the contact to get the call area. We can never miss that area. So if I did my 1 through 16 on the buccal, and then I did my 1 through 16 on the lingual, well, I'm still in a good position now to do 17 through 32 because I'm in the right clock position, and then I would use my mirror. And then remember, this is an assessment instrument, so I can be 1 to 4 teeth away, and I can reach. So this is what I do here too, is I'm going to be on 17. I'm probably probed here on, my fulcrum's on tooth number 21, but guess what? I can reach my probe back. We're not worrying about so much tactile sensitivity here. I don't need to be on that shank so much. And then I'm going to start at that distal line angle. I'm going to walk it back. Now there's no contact here. So just go halfway across and record the deepest number from the distal line angle to halfway across. You're going to come back at that distal line angle now. You're going to be recording your middle number, which is between the line angles. And then at the mesial line angle, you're going to walk in, you get the contact, you're going to pivot a little bit to get under that call. And you're going to repeat this all the way across. I put a line on this one too, go halfway across, because then you'll get, from the lingual aspect, you'll go halfway across. So you're going to continue on. Now, as you start to get to these anterior teeth, you have a choice. If you're comfortable, you can, stay in this clock position as you do these anterior teeth. But I myself, I get to about this point and I'm not so comfortable, and I might change to an 8 o'clock position. And then I change to an 8 o'clock position. I have my patient turn their head a little bit. And then let's just say I'm going to start, on tooth number 23. And I would, same process, walk it back, deepest number, and I'm walking. Now, do you notice that on these teeth that are such conical shaped teeth, that when I get onto this distal here, that probe is staying in alignment with that? In other words, you might think that this is parallel to that tooth, but if that's parallel, you would be jutting out into the tissue. So keeping that 1 to 2 millimeters of any side adapted, it should stay in alignment with the shape of that tooth. And that's staying adapted. So you're going to come all the way across, and then you can have your person turn their head a little bit as you come across and do the rest of your facial aspect or buccal aspect here. Now, I'm in this 8 o'clock position for this, and so my next sequence would be starting at 17 lingual and doing the entire lingual of this mandibular arch, and I'd use my mirror, and I'd start most distal, and it's the same process, and then you can figure out your clock positions. I usually probably come to about tooth 22, 23, and then I go back to my 12 o'clock, and then I can finish out my probings much more easier in a 12 o'clock and then to a 10 or 11 as I do the surfaces away on this lower right. So our clock positions are pretty much the same as they always are, even though you're going in a continuous manner with your sequence, and you're going to need to adjust your clock position in the patient's head accordingly as you move. Now, if you have a recorder, you're just calling out your numbers and they're recording it for you. If you are recording it for yourself, and if all your numbers are within normal range, like they're 3, 2, 3, 3, 2, 3, then maybe you can get by with doing 2 or 3 teeth before you go ahead and write it down, or use your computer keyboard to put those numbers in. But if you get a 4 or bleeding, I would encourage you to stop, record it right away so you don't forget, which surface that bleeding took place, so you have accurate readings. So some clinicians will do all of their probe depths first, then they'll go back and do their recession. That's up to you. Let's just say that on this tooth right here, we'll call that recession. I need a different pencil. Doesn't want to make a line on it. So we'll just say that that's the CEJ right here. So then remember how to record recession. We'd go from the fixed reference point of the CEJ to the gingival margin. So I'd probably call that recession 3. You had the blunt probe right on that gingival margin, and if that was my CEJ, that would be a 3 millimeter recession that I would record. How do we record mobility? You would use the end of single-ended instruments. And so you have the mirror and you have your cotton plywood, which is the only other instrument that you have that is single-ended. I don't have a pair in here, but I do have another. I can get it out. There we go. So you would take 2 blunted instruments and you would go back and forth. And if the tooth moves 1 millimeter, you would record a 1. If the mobility is greater, 2, then you would record a 2. If it's depressible, so if it's moving back and forth and you can depress it, it's a 3. I think it's a 3. So anyway, so we have to make sure we're recording all of the information, the probe depth, the recession, the bleeding on probing, the mobility. And then remember, for our attachment level, and I'll use this one because this one's down. If I call this the mucogingival junction, things don't want to write for me today. Okay, so if that is my mucogingival junction right here, and that's my gingival margin, I would take my probe and I would go to the mucogingival junction and then read up into the gingival margin. And I would probably call that about a 7 maybe, or a 6. Let's go right there to this. We'll call that a 6. And then if I insert the probe and my probe goes down to a 5, that means I'd have to subtract 5 from 6, and my attachment level would only be 1 millimeter. So that's very important for us to also record. If our person does not have a lot of attachment, then they might need to see a dentist for to have that repaired or monitored at least. So those are that's our probing.